Okay, I think we should be recording. Okay, so I am gonna go through these last 4 or 5 lectures here. Um, Unfortunately, I'm gonna have to move pretty fast because I am actually going to be tutoring myself here in an hour. So I think at this point, probably what's gonna help you most, if I can just go through and kind of clue you in, to what is high yield and what's important. Okay. Um, we'll start here with the triangles of the neck. So before I start with this, I've got a lot of messages about uh, how was this exam and people worried about passing. To be completely honest with you, you guys have had almost completely different lectures than we did last year, with the exception of like Dr. Gassler and Jonathan. So it's been mostly different people. Like the lecture objectives and the material, of course, is pretty much identical. But as far as, me being able to guarantee what they will ask or won't ask, I mean, it's really just hard to do because, every all the people that you guys have had are different. Um, but so, anyways, all right. Um, so here with all these fascial layers in the neck, um, the main point or biggest thing that I would worry about here is what's known as the retropharyngeal space. So this is a potential space between this buccopharyngeal fascia here in green and then the prevertebral fascia. So why that's clinically significant is because it allows for the spread of infection into the superior mediastinum. So if you're going to be asked something about one of these layers, it's going to be this point right here. And then, of course, I would definitely recommend knowing the contents of the carotid sheath. So the common carotid artery, the internal jugular vein, and your vagus nerve. So 2 points here that are very important. All right. Be able to identify the platysma muscle, uh, and that it's innervated by cranial nerve 7. So this should be a pretty big, easy, obvious one if they were to tag it. Okay. Next we have the scalenes, and what you want to realize here is that these are a very important landmark. So between the anterior and middle scalenes, you have what's known as the scalene interval, where you'll find your brachial plexus and subclavian artery. So I know for me, when I was nervous in a practical, sometimes I had trouble orienting myself. So this is, just one of those things that you can look for to try to establish where you're at. And then as far as taggable things go, I would know that the phrenic nerve is running on top of the anterior scalene. Um, and what nerve roots contribute to the phrenic nerve? Yeah, right. So C3, C4, C5 keeps the diaphragm alive. Remember that. All right. Uh, Next, we have the suprahyoid muscles. So the biggest thing I want to point out here is this stylohyoid muscle and the fact that it's splitting around the posterior belly of the digastric muscle. So this one is very obvious in lab. So this is one way you can identify it, and then you'll also see it running from the styloid process down here to the hyoid bone. So this is definitely one that they tagged last year. And then also knowing that it's innervated by cranial nerve 7. And if you think about how cranial nerve 7 exits the stylomastoid foramen, you're right in that area. So hopefully that helps you remember that both the posterior belly of the digastric and the stylohyoid muscle are both innervated by cranial nerve 7. Okay, and then here's just a nice donor picture to study from. Okay, so one of the tags on the practical could definitely be just as simple as identifying one of these strap muscles. So you have omohyoid, sternohyoid, sternothyroid, and thyrohyoid. And I mean, you've probably figured this out by now, but if you just let the words work for you, it tells you where it's coming from and where it's going. So like sternohyoid from the sternum up to the hyoid bone, sternothyroid from the sternum up to the thyroid, and so on. Definitely, be able to identify all of these strap muscles, really all muscles, whether it be face muscles, neck muscles. The tags could definitely be that simple. And, if you're not able to identify them, that's definitely just like giving up easy points. Okay, see what question. Yeah, sorry, I missed your question. Yeah, so stylohyoid, styloid process to the hyoid bone. So that tells you that it's stylohyoid. And then also you can see it splitting. Yeah, the PowerPoint should be up on my Google Drive. So you could see the stylohyoid splitting around the posterior belly of the digastric. And so those two things should clue you in. And they tagged this one last year. So I definitely want to know that. Okay. Okay, I'm not going to make any promises, but this is how it was last year. So Dr. Hermy last year, she came out and told us that she would not test specifically on the borders of these triangles. However, knowing the contents was more important. So I think Aaron, is his name right? Yeah, Aaron taught this lecture. I can't make any promises what he'll do, but I think it might be a little mean and not super important to try to test you on the boundaries of these, especially when they try to keep it a little more clinically oriented and significant. So if you have time, learn these, but if not, I don't know that it's like the highest yield of your time to sit down and memorize exactly the borders of these. But again, I can't make any promises. One big thing I want to point out here is this big muscle right here. So the sternocleidomastoid is innervated by cranial nerve 11. And I want to say maybe they tagged this last year and asked for the innervation, or they might have tagged cranial nerve 11 and they showed it innervating the sternocleidomastoid. So I would pay attention to that. Yeah, but if you're triaging, maybe on the lower yield of things. Okay. I don't remember being asked anything on the lecture exam about the thyroid gland. Just know where it's at in lab. I wouldn't worry too much about parathyroid, too small. Okay, so arteries of the neck. I would try, I would know this. Okay, so the mnemonic that I use for this, so branches of the subclavian, you have vitamin C and D, and I think, what was it, upper limb? I think you've learned a lot of this already. Okay, so vertebral, right here, your internal thoracic, your thyrocervical trunk, costocervical, and dorsal-scapular. These are really the three branches that are new to this material. So I would focus in on learning these. Okay. So as far as arteries of the neck go, uh, you definitely want to know these. So mnemonic is some aggressive levers find odd positions more stimulating. They might tag one or two. The one that I want to say they tagged last year was the lingual artery, and you can see it running here with the hypoglossal nerve. So I would look for this relationship in the neck between cranial nerve 12 and the lingual artery. And then, these other ones, you really just have to look at where it's going. Because of course, I mean, by now you figured out, there is variation, to all of this branching. So I would definitely look at where it's going when you're identifying which branch of the external carotid it is. But I would say, as far as like most likely tag, probably lingual and cranial nerve 12. Okay. Donor pictures that you can study from. All right, so I would know the difference between the carotid sinus and the carotid body. So your carotid sinus is like a pressure or baroreceptor. So that's detecting any change in dilation in your internal carotid. And then your carotid body is acting as a chemo receptor, detecting any change in oxygen levels. So I want to say that, and sorry, I should put a star here. I believe this was a lecture question in some form last year. So know the difference between carotid sinus and carotid body. All right. So typically they don't get too crazy about veins in the practical, but I would definitely know this pattern. So last year we had a question about the veins forming the external jugular. So that's posterior auricular and the retromandibular vein. So coming together to form the external jugular. Okay. So as far as the cervical plexus goes, I would say a lot of these tiny branches are probably destroyed by now. So you're probably more likely to see this on a lecture exam. So I would make sure you know which branches are providing sensory versus motor innervation. So I know he used some mnemonic I hadn't heard before. Something, something treading softly. I don't know. Does anyone remember it? Something about, oh yeah, little goat. Thank you. Little goats tread softly. Wasn't that it? Okay. But also, I mean, they're named for where they're going. So lesser occipital, back toward the occipital region, greater auricular around the ear, transverse cervical, I believe is running across the SCM, and then supraclavicular down towards the clavicle. And then your ansa cervicalis supplying motor innervation to the strap muscles. Okay. Providing, yeah, I think so. Yes, the ones providing sensory. But these down here to the strap muscles are motor innervation. Alrighty. Okay, so sorry we're breezing through this. I just want to let you guys get back to studying. Okay, so the nasal cavity. So here, just being able to label things was a big deal in the practical last year. So they could ask you something as simple as sticking a tag in either the inferior, middle, or superior meatus. And just make sure that you don't screw it up. That's the best thing I could say. So start, from the bottom and work your way up, identifying which one is inferior versus middle versus superior. Okay, so something that got a lot of people last year, they tagged this structure right here. So the torus tubarius. And I feel like it's a little tricky because it barely comes up in lecture. So make sure you can identify the torus tubarius. And you can double check, but it was on the lab list last year. So if it's there again, I would make sure that you can find this in lab. Alrighty, keep going. Oh, something else that was tagged last year was this ethmoid bulla. And then make sure you can identify the semilunar hiatus as well. Okay, so a lot of this is just, just literally, being able to identify the structures. Okay. So you want to know the innervation of the nasal cavity. So everything in this yellow area is innervated by V1 mostly, and then V2 is more posterior and inferior. I don't really remember any sort of question about that, but right here, okay, so here's a potential question with a clinical correlate. So Kiesel box plexus, if you have a kid or potentially an adult who, sticks their finger up their nose and they scratch this nasal mucosa. So this area in the nasal cavity is very highly vascularized, and this can lead to epistaxis or a nosebleed. So I believe Dr. Kim, she said not to worry about these smaller branches, just to know that Kiesel box plexus is made up of a contribution of smaller branches of the maxillary, the facial, and the ophthalmic artery. So I could see a question coming from this for sure. And I think we were asked about it last year as well. All right, she did spend a lot of time on this right here. So where each of these sinuses are draining. So to get through to the sphenoid sinus, you go through the sphenoidal opening and I believe it's the sphenoethmoidal recess, and to get to the posterior ethmoid sinus through the superior meatus, and then the middle meatus for maxillary, anterior ethmoid, and frontal sinuses. And then the inferior meatus is associated with the nasolacrimal duct. So I would definitely know this area right here of the chart, because they could definitely come up with a question from this here. And she seemed to spend a lot of time on this. So I would say high yield right here. Also on the lab practical last year, you know how they put the imaging up on the screen? We were asked to identify one of the sinuses. So make sure you look at this, because I would say, I doubt if maybe they'll be nice and give you something easy like maxillary, but I would say more likely you'll see something like the sphenoid sinus or ethmoid. So make sure you know that ethmoid, if you get this lateral view, the ethmoid sits more anterior to sphenoid. Okay. So we've talked about the orbital blowout fracture before. So we did get a question about that last year, as far as like which direction the contents are most likely to herniate. So it would be either inferiorly or medially. I think inferiorly is a bit more common. Or they might give you an answer choice that says like inferomedially. So that's what you would want to pick. Okay. Okay, so the only thing I would really worry about from this slide is the fact that you find your palatine tonsils between the palatoglossal and palatopharyngeal folds. And remember, those are just mucosa that are like covering the palatoglossus and the palatopharyngeus muscle. Okay, so has everyone seen or found the constrictors in lab or seen a donor that has these constrictors dissected out? Have you seen this view? Yeah, okay. So make sure you study this view. They like to use this view in a disarticulated view. Okay, so the way you tell the difference between superior, middle, and inferior constrictor is, let me move this over. So this muscle right here, the stylopharyngeus inserts between the superior and middle constrictor. Okay, and remember, I think this has come up like every session we've had, but remember the stylopharyngeus is innervated by cranial nerve 9. So cranial nerve 9 only supplies motor innervation to one muscle, and that's the stylopharyngeus. So I like 99.9% sure, I would bet money that you're going to get asked something about this. Either you'll have to identify the stylopharyngeus, or they're going to tag cranial nerve 9 innervating the stylopharyngeus, or they could show you this relationship, and by that you could identify which constrictor is superior versus middle with this relationship here. Okay, so right here, very important. What else? Okay, so salpingo pharyngeus and palatopharyngeus, be able to identify those two muscles. I think there's a better picture of those in here. All right, so let's keep going. All right, this is the disarticulated view that I was talking about. So you have a donor in lab that's dissected like this, yes? Have you guys seen this view? Yeah? Okay. So again, you want to be able to identify the glossopharyngeal nerve. It's very small, but they will tag it. And then also, very important, this will probably be the view where they can tag the contents of the carotid sheath. So make sure you look at this in lab, and you can, identify what is what. So vagus nerve, the internal jugular vein, and the common carotid artery. And then also the sympathetic chain. That's definitely something they could tag as well. So know the difference between these four structures, and then glossopharyngeal. Then your constrictors, and you'll be good for that view. But for sure, questions are coming from here. Okay. The gag reflex. Really, all I can say is just know it. I mean, know that there's a sensor limb and a motor limb. The sensor is cranial nerve 9 and the motor is cranial nerve 10. Let's see. Oh, also, okay, so I know I have more pictures of this in here, but I can't say this enough. So tensor veli palatini and levator veli palatini, they love to show that relationship and tag one of those. So make sure you know that the tensor is V3 and the levator is cranial nerve 10. But we'll get to that picture. And she spent a long time on that in lecture. So that's definitely coming. Okay. Okay, so two things here. Be able to identify your piriform recess. So the piriform recess is on either side of the epiglottis, and it allows for passage of food from the laryngopharynx down into the esophagus. And then also, I want to say they might have typed this last year, the vallecula. So that's this area back here where food particles can get stuck. I don't know why they don't bring up intubation because that's actually its most clinically significant purpose. So if you're intubating somebody, you're going to stick the blade down the vallecula to move the epiglottis out of the way so you can visualize the airway. So that's a really, I mean, in my opinion, that's why that structure is most important clinically. All right. Okay, so the larynx. Do you guys have a larynx model there in the lab? Yes, no? Yeah, okay. Study that thing. Um, the larynx, it's not that bad. It just takes a little bit, to get all of you're just identifying the parts, okay? So it just takes a little time, but spend the time because I think last year um, we had a couple tags on the larynx model, and then there's also one important muscle that they tagged on the donor. So I'll show you that when we get there. Um, but really, this isn't too bad. Okay, so thyrohyoid membrane. Let's see what else. Cricoid cartilage, your thyroid cartilage. Be able to identify the epiglottis, the cricotracheal ligament. Okay, let's keep going. Okay, so know the difference between sorry, let me move this out of the way. The quadrangular membrane and, trying to see where it's labeled, the cricothyroid ligament. Okay, so your quadrangular membrane, so it's from the lateral epiglottis to the carniculate and thyroid cartilages, and then it's forming here in the middle this vestibular ligament on either side. So this is part of what's known as your false vocal folds. And then down here, the cricothyroid ligament. In the middle here is the vocal ligament, forming the true vocal folds. Okay, so this view right here, I believe was tagged. So again, just identifying. So above the ventricle is known as the vestibule. Below it is the infraglottic space. And then you have your true and false or vestibular folds. And then knowing the innervation is also important. So they could tag an area down here and ask for the innervation. So if you're below the vocal folds, it's the recurrent laryngeal. And if you're above the vocal folds, it's the internal branch of the superior laryngeal. So, and yeah, this is a good picture. This is exactly how they would do it, kind of having this section down the middle here, and then they can tag it directly on the donor. Okay. So right here, it's just a matter of, definitions. So knowing the difference between the rima vestibuli and the rima glottis. So the rima vestibuli is the opening between your vestibular or false vocal folds, and then the rima glottis is the opening between the true vocal folds. So I want to say there was a lecture question that came from this last year. I don't remember, don't quote me on this, but I don't remember being asked specifically about this. So don't worry too much about that. What is important though? Okay, so the external branch of the superior laryngeal is innervating one muscle, and that's this cricothyroid muscle. And then I want to say, oh yeah, here. Okay, so last year, this is the muscle that was tagged. This posterior cricoarytenoid was tagged in the donor. And if you give me just a second, in the next slide, there's a picture of that. Um, let's just go there. Okay. Yeah, posterior cricoarytenoid. Okay, so they tagged this on the donor and they asked for the function. So this is the only intrinsic laryngeal muscle that is abducting the vocal folds. Okay, so this is your one exception, and obviously you know by now they like to ask about the exceptions. So this is the one I would say is very important to know. And I think, I don't know if you guys saw that high yield like lab review that was shared with us last year. And it was like very representative of like what the real practical was like. So I would definitely take a look at that. Okay. Blood supply. Don't remember any questions coming from that. Don't worry too much about this stuff. So with the larynx, really the main thing is being able to, identify all the parts, identify all the muscles, and know your innervations. Okay. Go into oral cavity. I believe it's the recurrent laryngeal nerve. Yeah, it's the recurrent laryngeal. You're welcome. Okay. So I listened to Dr. Kim's lecture and she seemed like pretty awesome and straightforward. So hopefully you'll get some really nice fair lecture questions from her. Okay, so she spent a little bit of time. I think she made a comment like, you want to remember these foramen in the hard palate and what's being transmitted through them. So through the incisive foramen, you have the nasopalatine nerve, and then through the greater and lesser palatine foramen, or foramina, you have the greater and lesser palatine nerves. And then you can also see, the different areas that are being innervated by these nerves in the hard palate. Okay. Oh, here's the picture. Okay. So this is the one that she spent a lot of time on, and that they definitely tagged last year. So tensor veli palatini versus levator veli palatini. So, and then different innervation. So V3 versus cranial nerve 10. And then I think last time I showed you that list of like rules about innervations. I want to say it's I thought it was in here again somewhere. But if you look at the PowerPoint from last time, there's a slide that gives you like a list of rules as far as innervation goes to help you remember. Okay, keep going. Okay, so she had both of these, I think, in red boxes on her slide. So knowing the mylohyoid versus the geniohyoid and their innervations. And then also knowing that this lingual nerve runs underneath the submandibular duct. And I think I have another slide on this in here. So let's keep going. Okay. All right, so a couple really important clinical correlates. So one question that we got last year was right here. So it was like, patient has a lesion to cranial nerve 12 on the right side. Which way is the tongue going to deviate? So it's going to deviate towards the right side or the ipsilateral side. So be sure that you're comfortable with the meaning of ipsilateral versus contralateral, because that's how they will present the answer choices. All right. Let's see what else. Oh, she talked about knowing the difference in function between the genioglosses and the styloglosses. So your genioglosses is responsible for protruding the tongue, and then your styloglosses is retracts or pulls the tongue, back in your mouth. Other than that, I would say the hardest thing about this area is just being able to identify the muscles. So make sure you're looking at this area in lab. Because like I said, some of the tags are just as easy as, can you identify the muscle that they tagged? Which can be tricky. I shouldn't say it's easy because it's actually tricky, especially in this area. So spend some time making sure you at least get your muscles down. Okay, and then also, we weren't asked about this, but another possibility would be a lesion to cranial nerve 10, causing the uvula to deviate to the contralateral side. Okay. Donor picture to study from. I want to say that they did have some sort of tag from this view too. So make sure you know the layers here: mylohyoid, geniohyoid, and then genioglossus. Okay. So the two things I would focus on here is knowing where the sulcus terminalis is, and then knowing that the foramen cecum is a remnant of the thyroglossal duct. Also, I wouldn't worry about taste buds. Well, okay. Worry about taste buds for histo, but not for anatomy. Okay. This slide is extremely important. I can guarantee that you'll get a question about this slide. Okay, so the difference in innervation between the anterior part of the tongue and the posterior part of the tongue. So posterior is pretty easy to remember because taste and sensation is coming from cranial nerve 9. But from the anterior tongue, you have general sensation from V3, and then taste sensation from the chorda tympani, which is part of cranial nerve 7. And then, okay, so the other important thing to know is that the motor innervation to the tongue is being supplied by cranial nerve 12. So cranial nerve 12 associate with motor innervation of the tongue. But you're definitely getting a question from here. I mean, I think it's been brought up like a dozen times, right, about the tongue and its innervation. Okay. Yes, here it is. Okay, so this relationship right here between the lingual nerve and the submandibular duct. You can see how it crosses here, and then the lingual nerve runs underneath the submandibular duct. I would do your best to find this relationship in lab, or I mean, you can just remember this picture. But they did tag this last year, and then they could also ask a lecture question about this. So if somebody has surgery, some sort of surgery having to do with this duct, they can hit the lingual nerve, and then you're losing sensation and taste from the anterior 2/3 of the tongue. Okay, so yeah, and I thought she just came out and said, I think she came out and said, like, you want to remember this. So This is a question for sure. So, plus 1 point for the slide. Okay. I just threw this in straight from her lecture. Um, they they didn't really explain this to us last year, but this is good. So above this line, the glands are innervated by the greater petrosal, and below by the chorda tympani. And then your big exception here is the parotid gland, postganglionics from cranial nerve 9. I wouldn't worry too much about this. I just left this in here. Same with this. Lymphatics were not part of her objectives. She seemed to go out of her way to say that she was only going to test on objectives. Ankyloglossia. Don't remember being asked about this, but just in case, they're cutting the lingual frenulum because otherwise the baby can have problem with feeds. I doubt you'll be asked about that though. And then teeth. The only thing her objective said was to know the innervation of the teeth. And also this relationship right here. So the inferior alveolar nerve entering the mandible, and then the mylohyoid right here. I would definitely know that relationship. So they can put a string around either mylohyoid or inferior alveolar and show it going into the mandible. So it's innervating these mandibular teeth. They're going to numb it if you have a dental procedure. And then also coming out the mental foramen off of the inferior alveolar is the mental nerve getting this chin area. So just know that, and then that the maxillary teeth are being innervated by the superior alveolar nerve, which is coming from V2. So you have your top teeth, it's from V2, and the bottom teeth is from V3. I could see that. I think she would have an easy time coming up with a lecture question related to that. Okay, as far as this goes, do not worry about this for anatomy. However, Dr. Campbell, I think it's her pathology slides, she has a bunch of red text going over the layers of the tooth. Know that. That just goes, yeah. So Dr. Campbell, red text, if she draws an X on her slide or a star, those are all things that you want to know. And then her practice questions. Pay very close attention to her practice questions. Okay. So, Allie did an amazing job of trying to summarize Dr. Leo's last lecture. So unfortunately, I don't have time to go through all of this because I have tutoring starting right now for cardio. But I did kind of breeze through his lecture, and honestly, it seems to be stuff that you've already talked about. So I would, learn all the other lectures, and then I would visit Dr. Leo's lecture as kind of like a summary. Because I think if you know all the other lectures, you're gonna know what he's talking about in his lecture. But if you need some guidance, you can kind of read through these, and she does a good job of summarizing the parasympathetics in this slide. Okay. Yeah, you're welcome. So hopefully I tried to just give you the high yield. I think, I feel like that's what you guys really need at this point. Um, I haven't looked outside lately, but it was snowing a lot. So how's the weather there? It's snowing? Yeah, we're all like crossing our fingers for a snow day up here. All right, well, good luck, you guys. I know you're all really stressed, but uh, oh, well, I bet you guys will be fine down there. Up here they don't know what a snowplow is, I don't think. Yeah, you're welcome.